nonprofit made up of volunteer lifeguards and healthcare professionals whose aim is to reduce drowning worldwide with both domestic and international programming and research program. It was founded by our next speaker, Dr. Justin Sempsrott, and he and they do trainings around the country. I spent a little time on their website. It's Ecuador, Peru, Asia, several places in Europe, of course, several places in the United States, teaching lifeguards. Justin himself is a lifeguard and has been for 1996. I'll note that when we were discussing in the board meeting that we wanted to invite a lifeguard, I voted for Pamela Anderson. And the vote went the other way, so we got the doc. Those are for the gentlemen in the audience, and then for the women, I thought, hey, what about Hugh Jackman? Has anybody seen that video of him saving people in the ocean? So we tried, unsuccessful, so we got the doc instead. Thank you very much.
So again, thank you very much to the chief and to everybody else. What a phenomenal speaker to follow. So I always wind up kind of on the scarier side of everything with the doom and gloom stuff and the medical treatment. So without further ado, by way of disclosure, I don't have any financial conflicts with any of the information provided. There are graphic images of both fatal and non-fatal drowning patients, and again, you certainly will not offend me if you need to step away. During those, I still get choked up and goosebumps as many times as I see them. And obviously, don't change what you do just because you heard one guy say it one time at a presentation, but nothing that I talk about is outside of standard accepted medical practice. These are my affiliations, but again, no conflict with any of the information provided. So we're going to talk mainly about the new 2015 CPR guidelines that came out, and really try and highlight the difference between drowning and cardiac causes of cardiac arrest, as well as the importance of team-focused CPR, something that I've talked to a lot of facility owners, not just water parks, but municipalities and private pools, is this idea of termination of resuscitation is new, and ways to prepare for that, as well as selective spinal immobilization. And most importantly, how to act like what you do matters, because it does. So for some of you who have seen me speak before, you'll see some early slides to catch everybody else up that hasn't, and then we'll get into the new stuff. But similar to cardiac arrest, there's actually a drowning chain of survival as well. And as we've all heard, it's prevention, rescue, and treatment. And most important piece of that is prevention. And if we talked about drowning the way we needed to, then this is what the chain of survival would look like. And analogous to our fire colleagues, sprinkler systems and fire alarms save far more lives every year than the biggest advances in turnout gear, fire trucks, burn therapy, or antibiotics. And for those of us that are tasked with responding and training lifeguards, this is where we spend all of our time in training, in the recognition and rescue, because this is the most technically difficult component. And we're going to talk about this last piece, which is to provide care as needed. And to really highlight the importance of prevention, this was some data that just came out of Brazil, and for their 2013-2014 season, they had 1.56 million lifeguard interventions, and 99.9% of them were preventative in nature. And as we go further down the chain, very few rescues and very, very few resuscitations, only 355 out of that almost 1.6 million. So really just highlighting the importance of prevention. And believe it or not, in the published medical literature, there are very few, if any, studies that show that lifeguards are good and effective. It took us decades to medically prove that smoking was bad for you, and that's where we are with lifeguards actually right now. So this is actually a really important study to show that lifeguards are actually effective. So drowning seems simple, right? Somebody goes in the water and they die, that's drowning. Before 2002, there were actually 33 different published definitions of drowning. 13 of the word drowning and 20 of the term near drowning. And some were opposite each other. Some said death before 24 hours, some said death after 24 hours. And the problem, which I was talking to Nick about this morning, was that somebody goes into the water, We pull them out, we resuscitate them, do CPR, send them to the hospital, and they're pronounced dead 3 hours, days, or weeks later, and their cause of death is listed as respiratory failure. And so it never actually gets tracked as a drowning statistic. And we as an agency can say nobody's ever drowned at our beach, because they didn't die by drowning, they died by respiratory failure. And so we said we need to talk about drowning as a process. So drowning is the process that starts when that person goes underwater and has difficulty breathing. At some point, that process is going to result in death. At some point before death, severe, moderate, mild, and hopefully no brain damage. And so there can only be 2 outcomes from the drowning process. You drown and you die, or you drown and you survive with or without some degree of brain damage. So everyone in here, raise your hand if you know somebody who has had a stroke or heart attack, and keep those hands up. Keep the hand up if that person is still alive. All right, very good. So we can all put our hands down. So we all know people who've had a heart attack or stroke and survived. You can drown and survive. There's no near drowning any more than there's near stroke or near heart attack. And for those people, we'll stick with stroke, that have had strokes, some survive and they require 24-hour care because they're completely paralyzed. Some go back to living a normal life with no deficit, and so goes the spectrum of drowning as well. And so we specifically said we're not going to use any of these terms anymore, and we're only going to talk about drowning as being fatal or non-fatal. Drowning is a process, not an outcome. Drowning does not equal death. Excuse me. So this is 17-month-old Austin Sinetti. The day after this video was taken, he will drown at his grandfather's pool in Las Vegas. Grandfather had a fence around his pool, but because he was having a party, he thought that it was unsightly and removed it and had it stowed away. He had a non-load-bearing cover over the pool. So after he was presumed missing for about 45 minutes is when somebody decided to check the pool. They peeled back the cover and found him floating in the water column, presumed to be underwater for about 10 to 15 minutes. So this is his mom, Sierra, in one of his early hospitalizations. And the reality of non-fatal drowning, as many in this room are aware, is that he required 24-hour care from a team of doctors, nurses, and therapists in his last year of life, just over 8 years after his initial drowning incident. He was completely dependent on the ventilator and a breathing tube. Here's Dad cutting his hair, and here with the rest of his family, including his twin sister. And what makes his story particularly heartbreaking is this is twin sister Autumn. And that morning she woke up and went to Mom and said, Bubba came to me in a dream last night and said, it's nobody's fault, everything's going to be okay. And then here he was pronounced dead just a couple of hours later. And again, as everyone in this room is, I'm sure, aware, this is the reality of non-fatal drowning and what we're working to prevent. And speaking to the absolute strength of some people, Sierra now works as a pediatric hospice nurse and is able to share some of her experiences with other families going through that transition. So I would ask you, sorry, the picture didn't come out. Are you EMS? So other than this being a shameless plug and all 3 of these being me, that's me with a beautiful bob haircut in 1997 and probably about 80 pounds lighter. But I would argue that everybody in this room is part of EMS. And if your emergency action plans for your lifeguards or for you ends with call EMS, you're already there. And so the Emergency Medical Services System was actually created in the U.S. in 1966 by the National Highway Transportation and Safety Administration because of all these car accidents that were going on. And they have a definition of EMS, and EMS includes agencies and organizations, both public and private, that's many of you, highly trained professionals, and an informed public that knows what to do in an emergency. So if you are an informed public that knows what to do in an emergency, you are part of EMS. Welcome to the team, right? There's no more call 911, you are 911. They are the next step. So the way these guidelines are developed, they come from the International Liaison Committee on Resuscitation. It was first formed in 1993. So believe it or not, before 1993, everybody just did their own thing. And from these organizations getting together in 1993, they said, what if we all worked together? It took until 1999 before they actually had their first conference together. And they said, all right, in 2000, we're going to do these guidelines every 5 years and put these big things out. Well, they did 2000, 5, 10, and 15. When they came out with the 2015 guidelines, they said, this is a huge pain. We are not going to do this 5-year process anymore. And so this is the last big CPR guideline that we'll see. From here on out, now that we no longer have to print textbooks, we can do online digital media. They'll just do smaller updates as we go along, as the science develops, instead of having this arbitrary number of every 5 years we are going to do this. But to many of us, this is what it feels like, how these guidelines come out. It's just these magical things get together. But this set of guidelines was the first time that they had a lot of evidence behind what they were doing, and they did this really bizarre thing that I don't understand why. They asked the public for their input, and so there was this huge online review process, and some of the things that wound up in the guidelines were because the general public wanted to know more about them. So switching gears a little bit, there are 326,000 cardiac arrests in the US every year that are attended to by EMS. So that excludes people that have heart attacks in hospitals, that excludes people who have heart attacks and then are just later pronounced dead or found dead. So this is EMS shows up on scene and initiates some sort of care. And that blue portion there is ventricular fibrillation, ventricular tachycardia. Those are the irregular heartbeats caused by obesity, high cholesterol, and all of those other heart risk factors that we think of. And then the vast majority are those other causes: drowning, stabbing, poisoning, car accidents, overdoses, and every other possible cause. And if you have one of the electrical system causes, you have a 1 in 3 chance of surviving to hospital discharge. For all those other causes, it's only a 10% chance of surviving to hospital discharge. And from a public health standpoint, the easiest thing to fix is that VFVT piece of the pie. And so that's where we really focus a lot of our treatment, because that can be fixed with chest compressions and an AED. Everything else is more complex. We're getting better at the everything else category, but where those guidelines are focused are on that VFVT piece of the pie. So the biggest changes for 2015 is we're getting better. We're starting to see improved survival all the way around, mostly in that VFVT category, but also in everything else as well. In first aid, from a public health standpoint, we've also started incorporating stroke assessment tools. And for the first time ever, they looked at how are we teaching this? Is 1 to 2 years of retraining adequate? And the answer is no. Skills drop off very quickly. So my anticipation is that in future guidelines, it might be a 2-year recertification period, but during that, every month, every 2 months, every 6 months, you're going to have some sort of continuing education or continuing training, which may be an online module or something like that. But we know that people forget these skills very quickly if they're not using it every day. And I love this is the out-of-hospital cardiac arrest chain of survival. And I really love on the bottom there where the blue overlap of lay rescuers and EMS. And it really acknowledges that there is a huge overlap. You are part of EMS, but you're also lay rescuers, whether you're off-duty at the grocery store or whether you're on duty at your pool or your facility doing swim lessons or lifeguarding. You are part of that emergency medical services system. And the reason why I keep emphasizing that so much, I'll get into later, but people can enter into these systems of care at different points. So if somebody's having chest pain and they get picked up by the ambulance and then they have their heart attack in the ambulance, well, they've entered there. If they have it when they get to the hospital, well, they've entered the cardiac arrest there, or if they had it before they arrived. So patients can enter into that cardiac chain of survival at different points. And we know that there is a huge disparity in these systems of care. And we know that there's a huge disparity in who survives and who doesn't. And that's why I think it's important to acknowledge that you are EMS, because if you are EMS, then you can make a difference in whether or not somebody survives or does not. And one of the big studies that came out about 15 years ago now was done. And these percentages were your percent chance of survival from a heart attack here within the US. So if you had a heart attack in Seattle, you had a 40% chance of surviving. If you had a heart attack in Alabama, you had an 8% chance of surviving. So what were they doing in Seattle that we weren't doing in Alabama, or vice versa? This isn't comparing countries or nations. This is within our own. And how do we find the best practice and get that out to everybody? And for me, that's what we've really done with these 2015 guidelines, is try and say, okay, how do we fine tune this? We kind of have the big picture together, but how do we fine tune this to get everybody up to that 40% level? And it really is by acting like what you do makes a difference. For years, and I'm sure our fire colleagues can attest to this, CPR in the pre-hospital setting was this ritualistic dance that we did around people before declaring them dead. And we often just felt like it was hopeless and futile when we showed up, instead of treating it like it mattered. So, to remind everybody before we get into the cardiac arrest stuff, these guidelines are written for that VF-VT category. So, I'm 65 years old. I smoke 2 packs a day. I have my bacon and yolk-only omelet before heading to Walmart in the morning. I get there, and I realize that Grandma has taken the handicap pass, so I gotta park way the hell over there and give myself a stress test walking through the parking lot. I take 1 step past the greeter, and I suddenly go unconscious. Why? Because my heart sucks, right? I suddenly went into an irregular rhythm. So any UFC fans out there? Yeah, all right. So you take an Olympic quality Brazilian Jiu-Jitsu athlete, you put him in a rear naked choke, occlude both carotid arteries, no blood flow to the brain. How long before they go unconscious? Yeah, a few seconds, 3 to 5 seconds. So an Olympic quality athlete with no blood going to the brain, they're unconscious in 3 to 5 seconds. Now me at Walmart, I go into an irregular heartbeat, no blood flow to the brain for 3 to 5 seconds, and then I go unconscious. So besides cholesterol, what is still in my blood? Oxygen, right? There's about 5 minutes worth of oxygen still in the top part of my lungs and in my blood. So when I collapse, forget about breathing. Just focus on doing chest compressions only to circulate the blood that's, the oxygenated blood that's already there. But is our chest compressions going to restart the heart? No, what is? The AED, right? So even the best chest compression out there is only going to give them about 25% of their cardiac output. So I want to get the AED on them as quickly as possible so we can shock them back into a normal rhythm and get blood flowing to the brain so that we don't have to keep doing our chest compressions. And then about 5 or 6 minutes into it, hopefully our fire and EMS colleagues are arriving and then they can do some other things. But even in their specific training, we're getting towards where they're not focusing as much on doing some of the fancy toys. We're getting them just to do chest compressions and an AED because that's what the person needs. But in drowning, now I'm me, otherwise healthy young guy, and I'm trapped underwater. And my oxygen level starts to drop, 100%, 70%, 20%, 0. At some point, my heart runs out of enough oxygen to keep beating. And then you pull me out of the water. If you just do chest compressions only, you're circulating blood that doesn't have any oxygen in it. So you have to give breathing and chest compressions. And analogous to a car, in cardiac arrest at Walmart, the car still has gas in it, still has oxygen, but the electrical system is out of whack, so you just need to jump start it before it runs out of gas. In drowning, all of the gas, the oxygen, is gone, and that's why the car stopped. So if you try and jump start it without refilling the gas, refilling the oxygen, then you're not going to be successful. So in cardiac causes of cardiac arrest, the heart stops, you need to circulate the oxygen that's already there. So do your compressions, airway breathing, or just chest compressions. In drowning kids or in trauma, if you think about it, if somebody's heart has stopped because all of their blood is on the pavement, are chest compressions going to help? No, right? You've got to put blood back into them. And that's that big piece of the pie that we're still working on because it's not as easy to fix as just an AED. So heart stops because no oxygen in the blood, and we still need to focus on ABCs. And it's there in black and white that CPR for healthcare providers should use the traditional ABC approach. But I know not everybody in here does healthcare provider. Many of you have community CPR training, and that's specifically addressed. That we know that ABC is better, but if we start with compressions first, because what we teach in community CPR, because these are the accountants, these are the soccer moms, these are the people that hopefully do this never ever in their life, but still take the CPR class for it. We don't want to confuse them with having to differentiate between two different kinds of patients. We just want them to start chest compressions and then do the breathing also, because it's only going to delay it by 18 seconds, and 10 minutes into it while you're waiting on the ambulance to arrive, it doesn't matter. It's all ABC and CAB as long as you're doing both in drowning. So early high-quality CPR, we know, saves lives. And this was specifically studied in the new guidelines. By doing CAB for the general public, it got people to start doing something faster. Giving mouth-to-mouth, giving rescue breaths is technically difficult. And by having them start with chest compressions, it gives them that even just 15 seconds to kind of clear their head, gives them a task to do while they're starting it, and it gets them to start something faster than just waiting. And then they specifically looked at, if you witness somebody collapse and you're by yourself, should you stay and do CPR or run and get the AED? And it's better to just get the AED as quickly as possible, because in the hospital, when we have somebody on a monitor and we see on that monitor that they go into one of those shockable rhythms, we don't start doing chest compressions. We just push the shock button, right? Because the faster we can do that, the better. Same thing if you witness somebody collapse and you're by yourself. Obviously, if we have this room full of people, we have enough resources that we can have somebody do chest compressions while they're getting the AED. But as soon as that AED arrives, in the Walmart scenario, get it on the patient and get them shot. But what about AEDs in drowning, right? Less than 10% of your drowning patients are going to benefit from an AED because they're from that big piece of the pie, not the shockable rhythm piece of the pie. So we still need to put the AED on our drowning patient, but it's not our top priority. Our top priority is doing good breaths and good compressions, and then once we've got that going, then we incorporate in the AED. So 10% is not zero. We still need to use it, but it's not our top priority. I always say if you're at Walmart, you use the AED to knock everybody out of the way, except the one person doing chest compressions. In drowning, you need to focus on the breathing, focus on the good compressions, and then incorporate the AED in as everything evolves. So for drowning in 2015 guidelines, they took a really wimpy stance and said, we already talked about this in 2010 and nothing changed, which was a little bit disappointing for me because I feel like a lot has changed. But the European Resuscitation Council took a more aggressive stance, and I really like what they've done. And so what they do is unresponsive and not breathing, shout for help, call 911, open the airway, and immediately give 5 rescue breaths. So at Starfish, all of our guards do 5 breaths. State of North Carolina, California state parks, everyone in Europe starts with 5 breaths. And we don't know, is 4 the best, is 6 the best? We don't know. But we think that more is better than 2. And the American guidelines acknowledge that more than 2 is better, but they don't want to confuse the general public with more numbers. And so they say we're just going to stick with the 2. But if we're trying to get gas into the tank before we try and start it, well, let's put 5 breaths of gas instead of 2 breaths of gas and then try and go from there. And then their AED is all the way at the bottom in drowning. This is specific to drowning, not in Walmart. And so we're kind of talking about 2 parallel pathways here. So I really like what they did with their newest guidelines. So this is a facility. We're going to look in the bottom right of the screen. This guy was walking towards the stairs. So presumably is going in and out of an irregular heart rhythm, not getting blood flow to the brain. But by virtue of him being in the water and his body able to lay horizontal, his heart no longer has to fight gravity, and he's getting some blood flow to his brain. Or his heart is intermittently going in and out of this irregular rhythm. He's a regular lap swimmer in his mid-50s at this facility. You can see it's 4:30 p.m. They close at 5. The lifeguard is all the way at the top left of the screen, doing her walk around, completely obscured from his position. So if you witness this happen, we need to treat him like he's at Walmart. Or we need to treat him like he just came out of the locker room. If you haven't witnessed this happen, you can only assume that maybe he drowned, and we have to treat him as a drowning. But it's not this clear-cut distinction when they're in and around the water about what happened. But if your lifeguard or you are vigilant enough to know, hey, this is our regular lap swimmer. He knows how to swim, and you see them suddenly collapse like this, then you know that it's probably cardiac. And as fate would have it, he regains consciousness right as she walks by. I know, you can't make this up. But now he has drawn her attention because she sees that he's not acting right. And in her interview, she just kept saying over and over, I thought he was drunk. He just kept telling me, leave me alone, I'm fine, and being really argumentative and combative. And as she's asking him, are you okay? Is something wrong? He just keeps saying, leave me alone, because he doesn't have oxygen satisfactorily going to his brain. He's not thinking clearly. And so she's arguing back and forth with him right here, realizes that something is wrong and that he needs to leave the water. This is the same as at Walmart. And statistically, at all of your facilities or wherever you are, you're more likely to encounter somebody having a primary cardiac event coming out of the locker room than you are a true drowning event. But how do we train our 15-year-old seasonal lifeguards to tell the difference between the two and act appropriately? So as you can imagine, as she goes to take him out of the water, now he's standing up completely, no more pressure from the water to help keep blood flow to the brain, and he loses consciousness. She does everything correctly and appropriately. EMS arrives, and unfortunately they're not able to regain pulses, and he's pronounced dead at the hospital. Unfortunately, people die, and even if we do everything right, and presumably his heart attack was just so massive that it wasn't recoverable. Of that 326,000 number, for half of them, this is difficult to say, so I'm trying to say it logically. For half of that 326,000, their first symptom of heart disease that they ever manifest is death. For half of them, their first symptom of heart disease that they manifest is death. So it can be difficult. So this is earlier this month at Pipeline. This in Hawaii. This is Dylan McGinn. Bodyboarder drops in on this wave. They're only in about 1.5 feet of water. Can you switch the audio cable over? They're only in about 1.5 feet of water. He's knocked unconscious when he hits the bottom, and is rescued by Guilherme. Guilherme Tavares is a Brazilian who works as a Hawaiian lifeguard and was just bodyboarding on his off hour. So he sees it immediately that he doesn't come up and performs the rescue. As you can imagine, very technically difficult with the equipment and resources. Volcom, the surf company, has a house right in front of there, and there were several of the surfers repairing the roof, and they saw this, and they're the ones that ran down with those foam boards and got there before the lifeguards as they watched this happen. So that's where the foam surfboards came from. So, not to be critical, because I've not spoken to any of the lifeguards that participated in this, but unfortunately, trying to be politically correct. Is anybody recording? The group that works with training these lifeguards and these surfers works for the Hawaii AED Foundation and teaches them compression-only CPR and the importance of the AED on everybody, and doesn't differentiate between drowning and other causes of cardiac arrest. So you'll see once they get him up on the beach, the lifeguards are primarily just focused on doing chest compressions, and even though somebody picks up the oxygen, it looks like they're about to start giving breaths, they don't, and instead focus on the AED and then letting the AED analyze. Again, I've not had an opportunity to speak to anybody that was involved with this other than their senior leadership, and they kind of stick by what they do. So you can see he's a big guy. But everybody just focuses. And again, it's easy if you don't train for it to fall back to your level of training. Nobody rises to the occasion. And compressions only. Here's the AED, and here's the oxygen sitting right here. It's harder to see on the screen on stage left. But the oxygen is just at the bottom with the bag valve mask attached. But the focus, another bag valve mask is being held up here. But the focus is just on the AED and suctioning. And no ventilations are given at all. Fortunately, as soon as EMS arrives, EMS starts ventilating him immediately, and he walked out of the hospital neurologically intact 48 hours later. So the guy in yellow holding up his arm is Guillermo, he's the lifeguard, and the guy with the sunglasses on is Dylan, who you just saw that looked like he was dead. Again, fortunately, EMS provided oxygenation immediately. It's easy to be critical of them in that stressful situation, but if you're not training specifically for that and know the difference, then you don't usually get that good outcome. I thought that this was great because I always say if you can find a way to teach a 15 or 16-year-old seasonal lifeguard the difference between the two and when to do this or that, then that's like the golden piece. And then I found this article at 5 o'clock this morning. Bystanders play crucial roles in ocean rescue of men off Spencer Beach Park. Lifeguard was in his tower, and somebody says, lifeguard, 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 lifeguard. Look out there. There was a snorkeler from Salt Lake City who was unconscious, about 275, 300 pounds. Lifeguard goes out and starts pulling him in. As he's pulling him in, he keeps feeling these thumps from the guy's automated internal defibrillator going off and shocking him as he was towing him in. So this is the piece to tell you that it was a cardiac event and not a drowning. If their internal defibrillator is shocking, then that's how you know. But I just thought that this was great. So obviously defibrillator is spelled wrong, but the lifeguard's towing him in, not knowing if it's drowning or cardiac, and as the guy's getting shocked, you know that it's now a cardiac issue as the primary and not drowning. Again, this was just published at 1:30 this morning, and so I don't know what the outcome is yet of this case. So for those of us that have been doing this a while, the 2005 guidelines were harder, faster, deeper. 2010 guidelines were even harder, even faster, even deeper. And in 2015, it's correct harder, correct faster, and correct deeper. And so this is the nuanced part. This is the part where it's difficult. And we recommend a chest compression rate of 100 to 120. Because if you go over 120, their chance of survival decreases. If you go under 100, their chance of survival decreases. So if your lifeguards are doing 125 compressions a minute or 95 compressions a minute, that person's chance of going home to their family decreases. Same with chest compression depth. From 2 to 2.4 inches, increased chance of survival. Less than that, greater than that, decreased chance of survival. You have to let the chest wall come up completely between chest compressions, and that's how the coronary arteries fill. So if the lifeguards aren't, or you aren't letting the chest fully refill, then you're not letting the blood get to the heart, and they have a decreased chance of survival. What about pauses in compressions in the AED? When you stop to give breaths, when you stop to put on the AED, and when you stop to analyze, those breaks can't be more than 10 seconds. And you do this calculation called chest compression fraction, which is from the time you started chest compressions to the time they're pronounced dead, or you get pulses back. Were you doing chest compressions at least 60% of that time? And if it's less than that, they have a decreased chance of survival. If it's 60% or greater, they have a better chance of survival. But with all of these things, if you're not measuring and looking at those things, then you don't know if those breaks are longer. So we know that high performance EMS, which you guys are all part of EMS now, so this applies to you, is a key component of the out-of-hospital cardiac arrest system of care. And you need to consider successful resuscitations the norm rather than the exception. And one of the ways that we do that is what we call pit crew or team-focused CPR. And we steal this from NASCAR. You put all of the equipment in a place to be efficient. Is the green bag with oxygen organized in a way that it's intuitive as the lifeguards are pulling things out? Are all of the roles pre-assigned? This is the big one. As you saw in that Hawaii rescue a few minutes ago, everybody just shows up and is trying to do the same 2 or 3 tasks all at once instead of 10 different people picking 10 different tasks. And you have to practice. Nobody rises to the occasion. Everybody falls back to their level of training. So this is a NASCAR stop. Right, so we have 5 people changing 4 tires and a tank of gas. And it takes about 20 seconds or so. If you have more people and more training, you can do it a lot faster. So this is a lot more people doing 4 tires and a tank of gas. In just under 3 seconds. So we'll watch that one again, because it goes by fast, right? If you have that many people around, and everybody knows what their job is, and everybody is practiced and working together, you can increase your efficiency, right? So you can have team-focused CPR with just 2 people. 2 people is enough to make you a team. And as additional people arrive, they know what that role is. And that could be something as simple as the first guard to arrive starts doing this. The next guard to arrive grabs this. Instead of everybody trying to get the oxygen or everybody trying to get the AED all at once. And by training on it, everybody knows what their job is. And everybody knows what their role is. And these are freely available online. And there's numerous examples of this that are available. And we did one specific for drowning as well, which we'll see in a moment. But this is from North Carolina, where we have 100 counties. And we randomly divided them into 2 groups, team-focused and not team-focused. So we had 50 in each category. And the column in red is the percentage of people that survived CPR by doing it the old way. Blue is the people that survived doing it the new way. No new drugs. The only thing difference was we said we're going to do this in an organized fashion instead of everybody just showing up and being confused. And what really matters is for the same data set, these are the percentages of people that walked out of the hospital neurologically intact. So went back with no deficits, back to being fathers, mothers, brothers, sisters, and uncles. Went back to their families and survived. And the only thing that the paramedics did different was they treated CPR like it mattered. And they said, we're going to take an organized approach to this. And first person does this, second person does this, third person does this. No new drugs, no new interventions other than taking an organized approach to it. And as a result, more people went home to their families, which is just mind-blowing because we think there has to be some big technological advancement in order to do that. And it was simply that they treated CPR like it mattered. So we developed one for the beach lifeguard crew where I live. And again, you adapt this to whatever your resources are. And it doesn't have to be anything that's complex. And we had successful resuscitations doing this with this ocean rescue team. The first person gets on scene and starts doing bag mask ventilation. Then the next person does chest compressions. Then the next person brings in the AED. And then they swap off compressors. And before this, were doing really good team-focused CPR for cardiac causes, but when it was an overdose patient, when it was a drowning, then they were still running around like chickens with their heads cut off. And so all we did was organize it a little bit more. So with this new team-focused CPR, we've also discovered that there's no magic in the ER. The paramedics and the EMTs are able to provide the same quality of care at the bedside in that person's living room that I'm able to in the ER. And the reason is, what we used to do, paramedics show up and say, that's bad, that's a heart attack, throw them in the back of the ambulance. While in the back of the ambulance, they're trying to start IVs, they're doing really bad chest compressions, stopping a lot to do other tasks, bouncing up and down the road, and that chest compression fraction was really, really low. And then they get to the ER, and right before you pull them out of the back, then you make everything look really pretty because you're about to go into the ER, and then you have somebody doing really good chest compressions, and everything is organized. So what we're doing now with our crews is they're staying on scene in people's living rooms, on your pool deck, and doing 30 minutes of CPR. And if they don't get a pulse back, we're declaring them dead on scene. If they get a pulse back, then they're bringing them to the hospital. And that's not everywhere. But I've heard stories and have talked to owners at community, municipal, and water park facilities where they're like, yes, that happened to us. We had a guy walking out of the locker room, he collapsed, they came, and then they pronounced him dead. So now what do? Are we allowed to move them? Do we have to keep them in the public view? And it differs jurisdiction to jurisdiction. Some places the police department shows up and releases EMS because the EMS doesn't need to be there anymore. There's nothing more that they can do. And that person, then the police determine, well, is there foul play? Is there not? Are we going to do an investigation? And you have to wait for the coroner to arrive, or somebody from the coroner's office, or a funeral home. And there's no easy answer other than, for those of you that operate facilities, talk to your local EMS and say, if we had a cardiac arrest at our facility, would you pronounce them dead here? If you did pronounce them dead, could we move them out of the public view? Could we move them into an office? How long would that take? Do you call the police? Do we need to call the police? And develop those plans. But this is very distressing for a lot of families, because if that's your mother, your father, what are you doing? Why are you here? Hurry up and take them to the hospital. And so on the back end, we as the EMS physicians are having to field these calls and say, no, they did the right thing. We don't want them to rush them to the hospital. The quality of care that they're able to provide is as good or better than delaying 30 minutes to get to us in the ER. And it's very distressing because we classically think of the paramedics as just scoop and run, but we don't. We want them to stay in place sometimes. So 2015 is the first time that they did first aid guidelines, and they define first aid as any helping behavior, which again is all of you and all of you as being part of EMS. So the biggest one in that was the stroke recognition. So we recommend that first aid providers, all of you now, because you're a helping hand as part of the EMS system, develop some kind of stroke training. So who here currently does stroke training for their guards or their facilities? Yeah, a handful of folks. So it's really easy. I just pulled all these online. The only difference between FAST and the Cincinnati Pre-Hospital Stroke Scale is the letter T, the time. So it's basically face, arms, and speech. And by training first aid providers to recognize this, gets them to the hospital sooner, because with stroke, with certain types of stroke, their best chance of survival is if we identify and give life-saving treatment within the first 4.5 hours. But if it's not recognized for 5 hours, then the options for treatment are significantly decreased, particularly in rural areas. And so I encourage you all to find some sort of stroke training to incorporate with your first aid training at your facilities. But again, it's very, very simple. And when they looked at these guidelines, they said this is an easy public health intervention that we can do to hopefully save more lives with a really easy training. The other big thing was bleeding control. So this is the first time that they've recommended hemostatic dressings. So these are types of gauze that have stuff in them that make bleeding stop. But they can be expensive. Some of these are $30 a bandage. And if you're close to EMS and you're not in a rural facility, it may not make sense for you to use these for your lifeguards, but this is the first time that they've put into these guidelines that you can use these dressings. And they acknowledge that there is a cost associated with this. And the other thing is tourniquets. So many of us grew up in Boy Scouts and Girl Scouts learning improvised tourniquets, and then they said, no, don't ever use a tourniquet. You're going to make them lose their arm or lose their leg. And from our experience in the armed conflicts in the Middle East, we know that tourniquets save lives. And these soldiers that are having tourniquets applied are living, and they're not losing their arms and legs as a result of the tourniquet. And so tourniquets are safe. And they actually even ruled that this is a basic first aid device, and you can purchase them without a prescription. So even just basic first aiders should be using tourniquets. And so it's okay. Commercial products are better than improvised tourniquets. And with anything good, there are knockoffs available. And so if you go to purchase your tourniquets and you notice that all of them are $30 except for one that's $6, that $6 one is probably a counterfeit one from China. And there have been documented deaths in U.S. servicemen as a result of counterfeit tourniquets, unfortunately. So they recognize that there's a cost in training, financially and in training to using tourniquets and hemostatic dressings, but if you feel that that's right for your facility, then that's something that you can use. So we got started 5 minutes late, so we'll finish in just 5 minutes. So the big thing in first aid is the cervical spine motion restriction. So for years we've used backboards. And what's going to happen when somebody falls, trip and fall, they're going to turn their head and then be paralyzed, and we're all going to be sued. They're going to take away our birthday, and we're never going to be able to do anything again. But that's just not the case. So they've actually recommended against the use of cervical collars by first aid providers. So some EMS agencies are still going to be using them, but they are going the way of the dodo. We are using them less and less because we're finding that they're actually harmful. Because we're putting collars on people to protect their neck, and then they're dying of suffocation. We're putting collars on them to protect their neck, and it's making unstable cervical fractures worse by pulling them apart. And less than 1% of your drowning patients have a spinal injury. And this is me right here, age 16. On one of my first, this was my second rescue. I was sitting in my tower. We've been pulling people out of this rip current all day. And I had just taken up the tower, and I watched this woman walk towards the rip current. I whistle at her, and when she's in knee-deep water, I'm already off my tower going after her, because by the time I get to her, we're 400 yards offshore. Get her in, she's unconscious and not breathing. Do you see any of us giving breaths? No. Why? Because we're so focused on our unconscious drowning protocol was they might have a spinal injury. I just watched her not have a spinal injury. But I was trained, and we were all trained to do that. She wound up surviving with no deficits, but again, we were so focused on the spine, that we forgot about the whole breathing thing. And these backboards don't immobilize the spine. They were actually designed as most people aren't born with handles. And when people are unconscious, they need handles to carry them. And so this is a device to give people handles. It was never designed as a tool for immobilizing the spine like we think of immobilizing a fracture with a splint or a cast. And these were the initial studies that were published that said this. And then there was one big study by a neurosurgeon that said, I bet it's EMS's fault that all these people are having worsening of their injuries later on, but there was no justification for it. And that was the reason why we started using backboards and collars on everybody. But it's an extrication tool, not an immobilization tool. And when you combine these two together, they're not really effective. You can still move the spine, and you're making it worse. People can start to develop pressure ulcers, bed sores, within 30 minutes of being on these. They get to the hospital, and they get more imaging. They get more expensive medical testing. They get more risk from the procedure itself. So they did this awesome study where they put all those little motion detector things like they use in making the Hulk movies and stuff. And they put people, healthy volunteers, in a simulated car accident. And they told some people, your neck hurts, just get out. and then they took everybody else and they did their usual care of putting collar and backboard and all these firefighters pulling them out. And who do you think had the least movement? The people who just got out by themselves and laid down on the board had the least movement in their neck. When they're awake, they have this thing called pain. It keeps them from moving their head and keeps them still. So let them be the guide and let them just hold it. So they also did another study and found that when we just let people walk on their own and hold their own neck, they have 4 times less movement of their spine. So if we're worried about holding the spine still, just let them hold their own spine still. And there's numerous studies showing harm, and there are numerous fatalities attributed to using C-collars and backboards. But there's no studies that show benefit. So injury is caused by energy and not motion. If you guys all remember your equation for kinetic energy, it's velocity squared, and it's only 1/2 of the mass. And to break your spine requires about 2,000 to 6,000 newtons of force. And they did this awesome study where they took cadavers and they lifted the head and just dropped it off the end of the table. And it only generated 40 newtons of force, not enough to break the bones in the spine and cause further injury. Dr. Oswald out of New Mexico did this awesome study where he compared a group in Malaysia that didn't have backboards. They just kind of threw people on the back of a donkey and got them to the hospital, and compared them to matched controls in New Mexico, and found that the group that just got thrown on a donkey had half of the disability of the people in the New Mexico group. And they were matched. This car accident, this age, this number of injuries, and found that we caused more harm with backboards and cervical collars. So the standing takedown is going away. If somebody's conscious and awake, they can hold their own neck. If somebody is unconscious and needs handles, we use the backboard to give them handles, but it's not an immobilization tool. And what I'm advocating for the starfish facilities is that they talk to their local EMS. And so they get them out of the water and they get them to a shaded area. Your neck hurts, okay, wait right here. And when the ambulance arrives, then you work with them. And their protocol may be to not put a backboard and not put a collar on them, and that's okay. Their protocol may be to put a backboard and a collar on them, and that's okay. And we'll go with that until they become more advanced. But these are going away, and major centers throughout the U.S. are going away from them. So we're going to look in the bottom right of the screen right here. This is a lap swimmer who stopped after her turn because she wasn't feeling well. Early 40s, healthy, no medical problems. Lifeguard right here. Lifeguard right here watches her, but sees her still moving from these convulsions of passing out, not a seizure. Doesn't quite believe what she's seeing. We now know later that she went into an irregular heart rhythm called torsade de pointe. But she's in an irregular heart rhythm, one of the shockable ones, and the lifeguard is looking at her still kind of in disbelief, like, what's going on?
Do something, come on.
Right? So eventually she reaches over the wall and pokes her with a stick, as we're all trained to do. Goes in, doesn't blow a whistle, doesn't activate an EAP, doesn't do anything else. We see her getting her towards the side. She then stops and turns around and starts going the other way. This is now 2.5 minutes later. She's literally swimming laps with this woman to keep her spine immobilized, right? Because she might have a spinal injury. So she's literally swimming laps with this woman to protect her spine. Gotta protect the spine. If they're unconscious in the shallow end, she just watched her not dive in the water. She literally watched her collapse, but her training, just like mine in 1996, was they might have a spinal injury. There's the backboard, and she's swimming like 12-meter laps with her to protect the spine, to protect the spine, to protect the spine. There were also other delays because the EAP was not activated. Other lifeguards were slow to clear the rest of the pool and get the AED over. Eventually, 8.5 minutes later, they get her out of the water, and the AED arrives just as the paramedics do. They put the AED on her, shock her, she gets pulses back, and walks out of the hospital neurologically intact. The next day, goes back and thanks the lifeguards for saving her life. Right? So again, this isn't because she was a bad person, but in talking to her, she's like, well, that's what we were trained. That's what we were trained. Her heart rate's 180 to 200. Her adrenaline is through the roof. And all she can think was, what was I trained to do? Focus on the spine, focus on the spine, focus on the spine, even when it was at the expense of the airway. So for the 2015 guidelines, the fundamentals are the same, but we need to measure our quality and make sure that we're doing things right instead of just harder and faster. Seat collars are out. Backboards are only for giving people handles that don't have them. Cardiac arrest is not hopeless. Train like what you do matters, and the only way to do that is to measure what you're doing. If you're not timing the brakes, if you're not measuring the rates of compression, and it's difficult because we spend so much time training on something that we hope we never have to use at our facility, but that our 16-year-old seasonal lifeguard might do on their first day, and what they do might make the difference between somebody going home to their family or being declared dead. With the termination of resuscitation, if you have a facility, talk to your local EMS and incorporate your stroke training and act like what you do matters, because it does. And because they're new, because they're just kids, because they're 16 is not a valid reason for why they didn't save somebody's life. We place tremendous weight on the shoulders of our lifeguards to act appropriately and to act correctly. And again, you guys are part of EMS, and so that's it. Thank you very much.
We're right up against the break, but I always like to give an opportunity for questions if you have them. We'll start right here. We maybe just have time for one or two, and that's it, very quick. You got your basket.
I got my basket.
You guys might decide, pull an adult out of the water, presumably a respiratory arrest, drowning. Are we doing 3 pumps, 2 breaths for that victim, or are we just doing chest compression?
And so the question was, if it's an adult, presumably a respiratory arrest that you're pulling out of the water, you should be doing compressions and breaths. If they're coming out of the water, compressions and breaths. If they're coming out of the locker room, then compression only until the AED arrives, and then compressions and breaths.